Okay, we're going to go ahead and get started now. Thank you everyone for waiting and for being here with us today. Good afternoon. My name is Charlie Hamadani. I'm the Community Relations Specialist here at Family Health Centers of San Diego. And it's my pleasure to welcome everyone to Spirit of the Barrio. As we said last year, it's difficult to envision our tradition of Spirit of the Barrio without the normal gatherings of friends and colleagues, the tents and the music, and of course the tamales. And I'd like to thank everyone for joining us today as we gather together, albeit not in person, but virtually, to dive in and learn about the opioid epidemic in America. As a reminder, this webinar will be recorded and will be made available via our website early next week. I will be sending out an email out to everyone with a link and a recording that you can view, and I ask that you please share it as however you see fit. You're welcome to do so. In this webinar, all of the guests will be muted, but I encourage all of you to submit your questions into the chat and we'll do our best to answer them as time permits. First, I would like to start out our presentation by thanking our amazing family of Spirit of the Barrio sponsors. Without the generosity of these partners, today's event and pandemic response efforts FHCSD has carried out would not be possible. So I want to encourage you to support these organizations during this time. So first, we have our Corazon sponsors, and I'd like to thank the Port of San Diego, Rancho Mesa, US Bank, Cox Communications, Community Health Group, and Medical Center Pharmacy for your support. Next, I'd like to thank our Adelante sponsors, Scripps Health, AO Reed & Co. Next, I'd like to thank our family of Fiesta Grande sponsors. I'd also like to thank our benefactor level sponsors as well. And finally, I'd like to thank our patron level of sponsors as well. So before moving forward, I'd like to ask each of you to continue supporting the work of FHCSD in the community. Please visit fhcsd.org/donate to learn more about our work in the community and to support our efforts with a donation. For ease, you can also text FHCSD for Family Health Centers of San Diego to 707070 as well. Thank you very much, and we appreciate your support. So we're going to get right into it. Excuse me. First, I'd like to introduce the District Attorney of San Diego, DA Summer Stephan. I'm going to share a quick introduction if I can. DA Summer Stephan has devoted her life to providing justice to the most vulnerable communities and is focused on advancing public safety with solutions to complex issues with a data-driven approach that works to address not only that works to address the root causes of crimes driven by mental illness and addiction. As district attorney of our county, she leads the second largest DA's office in California, serving as the people's prosecutor for San Diego County. DA Stephan also holds several leadership positions across public safety, including serving as the vice president of the National District Attorneys Association. She is also the co-chair of the California District Attorneys Association Human Trafficking Committee, and is the National Association of Women Judges Human Trafficking Committee. DA Stephan has also led the San Diego Opioid Project awareness campaign aimed at reducing the opioid overdoses in their county. DA Stephan has received her Bachelor of Arts from the University of California, Davis, and her Juris Doctor from the University of Pacific McGeorge School of Law. DA Stephan, I thank you so much for being here today. I'm going to hand over to you now.
Well, thank you so much for that warm introduction, and it's really an honor to be with you and to support all of the great work that the Family Health Centers of San Diego does every day to make our community healthier and stronger. We rely on your partnership because we know that in order to best serve our community, to grow a healthy community, a community that is united by dignity and health for everyone and safety for everyone, it takes all of us working together. So I was really overjoyed to be asked to say a few words here today to set off the program. So I just want to talk a little bit about the opioid epidemic really that we're having in San Diego County and across the nation, but I want to focus on San Diego County since this is a local effort, the Spirit of the Barrio, that is coming together to educate and strengthen our knowledge and awareness, because we know that knowledge is power. And we know that through knowledge and education, we can really prevent harm. And that is one of our stated missions at the district attorney's office. When I became the district attorney, having risen through the ranks for 28 years, I wanted our mission to reflect the ethical prosecution of crime, to keep our community safe, but to also reflect a very important aspect of protecting victims and also the prevention of harm. And that's why events like today that prevent harm and that help support those who are suffering from substance abuse and their families are really important to our mission. Over the last year, we have seen the opioid epidemic and overdoses, as represented by the measurable overdose number, really rise. So let me give you some data around that. But please remember that these data points represent people. They represent our community members. They're not just numbers. There are sisters, our brothers, there are children, our neighbors' children. They are our parents sometimes. And these individuals of all ages in San Diego needlessly lost their life to an overdose, an opioid overdose. But one of the focus areas that is really increasing the opioid overdoses is the introduction of fentanyl. Fentanyl has resulted in a triple effect rise in opioid overdoses. And why is that? Fentanyl is a very high intensity, high grade opioid. That's what it is at its core. But it can be placed and put into anything that appears legitimate, appears like a pharmaceutical pill. It can be put and has been mixed in a Percocet appearing pill, in Oxycontin appearing pill, in Adderall, in Xanax, which many of our kids, our youth, have been prescribed or they take off prescription. And it is also mixed into cocaine, into methamphetamine. And because it can be transported in very small amounts, we are the largest entryway for the United States. Our Mexico border is the largest entryway for fentanyl. Like I said, it can be transported in small amounts, but provide doses that can be lethal to a large segment of the population. With that, the fentanyl overdoses around the nation have risen, but here in San Diego, we have felt that impact, and we felt it every day. In 2019, we had 152 overdose deaths from fentanyl. And that's definitely so high, such terrible loss. And I talk to parents, I talk to people who've lost loved ones, and they don't know what to do. One day their loved one is there, the next day they are gone. They are gone because of fentanyl. Oftentimes not realizing they're taking fentanyl, thinking they're taking something even though illegal, illicit, not prescribed by a doctor. Still, it's something that they've used in the past, and while harmful, is not killing them in an instant. But in 2020, that 152 number, it rose to 462 overdose deaths. That is such a dramatic increase. And it is felt and has rippled throughout our community in terms of pain and anguish and grieving. This year, we are set to surpass 700. This is really, really a turning point. And we need everyone to become more educated, more aware, and to discuss it within their circles and to have an open discussion that takes down and tears down the stigma of substance abuse and really helps people share openly and find resources to get help. Resources that are offered at the Family Health Centers of San Diego, the County of San Diego, and several other locations. Our method of attacking this at the DA's office, yes, we do look at the drug dealers. We look at the organized crime, the syndicates that are trading in people's lives by mixing the fentanyl illicitly and thus taking life with that. But our focus is also on that prevention that I talked to you about. So we came together with a researcher that has shown real impact across the nation in this area. And with that agency created a marketing tool called the San Diego Opioid Project. It has left millions of impressions on social media, and it has had an inordinate amount of engagement, which is a good measure that it's actually penetrating and impacting how people think about buying pills or other drugs on the street and understanding what that means in terms of opioids and in terms of the risk of death, the very high risk. At this point in time, we have to continue those efforts, but we need to also make sure that to do that, that we take away the stigma so people can share the marketing, they can share the San Diego Opioid Project, and they can share that treatment is readily available. I know that Dr. Sepulveda joined us for a live forums that we started, and then also online forums to explain to our community this issue and how effective treatment modalities for opioid abuse are available, and that they actually work, and that they take away that pain of withdrawal, and they take away a lot of the things that allow people to focus on healing. But we do know that at this point in time, as we're coming out of COVID, that there's so many people that have lost connection, that are experiencing loneliness, that are experiencing increased mental health impacts. And we do know that those mental health impacts then drive use of and abuse of illicit substances. And this is why we need to double down on caring about our mental health, also destigmatizing mental health and behavioral health issues so that we don't have people rely on opioids to numb that pain, but rather have resources, professional as well as supportive peer groups to help them battle, to help them walk the walk, to help them in their journey. No one needs to do this alone. We need to come together as a community to address this major problem that we have. We know that together we are stronger, and we know that we absolutely need to save lives, and that we have to turn this around so that the needless loss of human beings, our loved ones, our neighbors, stops. I want to thank Yoli Apalategui, my director at the DA's office for government and community affairs, for staying in touch with you, understanding your needs, and helping us as a DA's office to be a good partner to the community and to your health centers and to everyone who is joining us here today. Thank you for this opportunity to do a welcome and give some insight into what is happening around our county.
Thank you. Thank you, DA Stefan, and thank you to your office. We're honored by having you here, and we thank you so much for your leadership and for the initiatives that you're taking on this. We appreciate it, and thank you for being here. I am now going to hand over the microphone to Dr. Sepulveda. Dr. Sepulveda is the Chief of Psychiatry here at Family Health Centers of San Diego. He's also the medical director of our substance use disorder programs. He oversees our medication assisted treatment MAT program. He has overseen many other programs as well. We have had Dr. Sepulveda here on staff with us for many, many years. We're honored to have him. And Dr. Sepulveda, I am going to give you the spotlight. All right, there you go.
All right, thank you, Charlie. Can you see my slide on the screen?
Let me see. I think I need to fix one thing really quick. Okay.
Okay. All right, well, thank you everyone for joining, and thank you to DA Summer for that very good description of what's going on with the opioid epidemic. I'm going to talk about addiction in general and also a focus on opioid use disorder, and we'll specifically discuss many of the points DA Summer made, which were addressing the stigma, science, and treatment behind this chronic brain disease. And with that, the agenda today we'll talk about opioids and what they are. We'll talk about stigma versus health, genetics, the role it plays in addiction, the neurobiology of addiction, which is well mapped out. How do we know this is truly a chronic brain disease? We'll go over some slides for that. And then we'll also we'll talk about how addiction is a treatable condition and Narcan specifically, how it saves lives and everyone should have access to that. So what are opioids or opiates? Opiates are naturally occurring compounds, and they primarily derive from this poppy seed here. And you can see that compounds such as morphine, codeine, and heroin are derived from this poppy. Here we have an example of black tar heroin, and this is what we prominently used to see much more of in the West Coast. We're seeing a mixture of what's called China white now, which was predominantly on the East Coast. But these are examples of different opioids that we have in the pharmaceutical setting, meaning in the hospital setting, morphine. There's codeine pills here, and we have white China heroin and black tar heroin. Now, what are opioids? Opioids are synthetically derived compounds, meaning they don't come from this plant. They're made in the lab. And this is what DA Summer was talking about, which was fentanyl is really driving a lot of the overdose deaths that we're seeing now in the community. Now, this chart here really points to the way the opioid epidemic evolved over time. We initially started with prescription pain pills and the over-prescribing of prescription pain pills. And then when we started clamping down on that and we got really savvy that that was contributing to a problem, then we started seeing heroin increase, which you can see here in this slide. And once fentanyl started hitting the streets, then we saw a significant uptake in fentanyl here. Now, this is up to 2017 data, but I can tell you without any doubt whatsoever, and with the newest numbers, that synthetic opioids, by far, fentanyl is the major culprit for overdose deaths. And this is an example of how much fentanyl you need to actually have an overdose. And you can see here in comparison to a penny, there's just a small amount of flakes, grains of salt. And the potency is 50 to 100 times more potent than morphine. So that's why we're seeing a lot of these deaths happen. And these are counterfeit pills here called M30. Blues are also the name in the street for these. They're illicit oxycodone pills that people are purchasing out in the street, and they're containing fentanyl. And there's a wide variety of other drugs that contain fentanyl as well. This is an example. This was a study that took place in 2020 and showed that right around 2015, we started seeing contamination of fentanyl into cocaine, which is a powder substance, but also in these crystallized methamphetamine drugs, which is harder to put in, but nevertheless, we're seeing this. And there's other substances such as Xanax pills and illicit Adderall. Now, the key point I want to make here is that these contaminated substances such as Xanax bars, Adderall, so on and so forth, these are illicit substances, meaning you're obtaining these from the street. This doesn't happen if you're having these prescribed by a physician and you're going to a pharmacy and picking up the medication. So these are specifically for illicit substances that people are purchasing on the streets that think they're getting Adderall, for example, or Xanax. So one of the things we really need to talk about is the stigma associated with addiction. This has really caused big problems in my field for years or decades, for people accessing treatment, being treated differently than other patients that we see in the medical community, and for really not viewing this for what it really is, which is a health problem. It's been really addressed through a societal problem, which is incarceration and arrest. But if we treat this like any other medical condition, we'll find really good benefits to patients' outcomes. So let's start with the basic building blocks of what a disease is in medicine, and that's really genetics. So if we look at genetic studies and we look at twin studies, what we know from those studies is that anywhere from a half to 3/4 of the risk of developing an addiction is solely based on your genetics alone. And we know that those that share an identical DNA component, such as identical twins, have a greater propensity for both twins developing an addiction solely because of this genetic characteristic that they share versus dizygotic twins, which do not share identical DNA. We also know that genetics plays a strong role as a driver for developing addiction, and is stronger than environmental factors, particularly for those that develop an addiction at a young age. So this is an example where we can where we compare the genetic heritability of developing an illness or a medical condition and we compare that with a substance use disorder. Now, the way to read this is if you see a 0, it means that there's no genetic contribution whatsoever for that disease process. The closer you come to the number 1, it means that 1 in and of itself means that the disease is completely genetic. And anywhere in between, there's a fraction of what genetics plays a role on. But if you look at the traditional medical illnesses such as hypertension, diabetes type 1, type 2, and asthma, what you'll find is when you compare that to heroin, marijuana, alcohol, or cigarette addiction, you'll find that the numbers are very comparable here with regards to the genetic component on what that role plays in developing that specific addiction. So really no difference from what we're treating in the general medical setting. The other thing that we know of, and we know this well, is that addiction really is a chronic brain disease. It truly is, and it can be treated like other chronic brain disease that we treat. So a question I often get is, well, how do you know it's a brain disease? Well, there's going to be several slides where I'm going to explain this, but let's start with layman's term. How does a person in the general community know someone has a brain disease? And usually they know because there's some form of behavioral expression that happens. So an example of that would be Alzheimer's. If an individual has severe memory loss, one can quickly identify that that individual has a brain disease, they have Alzheimer's, and they need to go and see a physician. And that's true of all of us in the community, or all of us that have family members that have Alzheimer's and know of this. If you have a family member, if you've seen someone with schizophrenia, then you'll know that that individual that's speaking to themselves or reacting to stimuli that really doesn't exist, which is auditory hallucinations, you'll know that that individual has a brain disease and they need to go and see a psychiatrist in order to receive treatment. Well, opioid addiction or opioid use disorder, their behavioral expression is cravings, which leads to uncontrollable compulsive use. And that is their manifestation of that disease. And that's often what gets them, unfortunately, into a lot of problems and where the stigma comes, where these cravings that lead to this compulsive use leads them to do things in order to attain the substance, such as, stealing from a loved one, or other individuals. And that's usually where the stigma comes from within families. The other thing that we know is that these behavioral expressions are precipitated by fundamental long-term changes in biological structures, meaning the brain. So here's an example of that. We know that someone that has an addiction has changes in their brain, and we know that because of these images called PET studies. And what you'll see here is a controlled, meaning that this individual does not have an addiction. And what we're specifically looking at in this slide is cocaine. And you can see that this fluorescent green is showing very good metabolism in the brain structure. But if someone has an addiction, what you'll see is that metabolism in the brain changes. So there's a change that happens to that biological tissue. This is analogous to what we see with heart disease. So if you look at the bottom slide here, when you look at heart metabolism, you'll see a healthy heart here with a bright red metabolism. When someone has a heart attack or someone has some kind of insult that happens to the heart, that metabolism changes, as we see over here, a diseased heart. So it's no different than the metabolic changes that happen in the brain, indicating that there is an organ in your body that is affected and driving this condition. We also know the neurobiology behind addiction. We've mapped this out over several decades, so we know how it works. We know that there's this area in the brain here in purple called the reptilian brain. And that reptilian brain is really where your dopamine is being driven. And that area of the brain, we call it a reptilian brain specifically because it reacts to things. So an example I give is an alligator knows to snap at any object that comes across them. It's not even a thought. They just automatically do it. And the reason they do it is because they know every time they snap at a moving object, the chances that they will get food and survive is significantly higher, thus driving dopamine in the brain, reinforcing that pattern or that effect. And that is what's really driven in addiction. Now, these red areas, these are your memory centers. This is where you get you remember that it's a pleasurable experience. And every time you see that in that cue, for example, for the crocodile, a moving object, they was going to prompt them to snap. So for a person that has an addiction, if they're given, if they talk about using the substance that they had a pleasurable effect from, if they see paraphernalia, if they're around the place where they use, well, then that's going to drive this purple center here. And these green centers, they're your reasoning, your thoughts, your ability to put the brakes on and say, well, I'm not going to do this because it's bad. Well, what we know from studies is that someone that has an addiction, these areas light up here, which is the purple and red area, and they shut down the green area. So essentially a person does not have the ability to stop, even though they have their best intentions at wanting to stop using substances. So addiction can happen to everybody. And we know that from the opioid epidemic when we overprescribe prescription opioids. Now, there's 3 studies that I like to outline here. One of the studies showed that if you're prescribed opioids for a long enough time at a high enough dose, and you'll have a 50% prevalence of developing a chronic opioid addiction. We also know that potency plays a role in this. So if you're prescribed an opioid for greater than 90 days at greater than 120 morphine equivalents, and that's a pretty potent dose. That's the way us doctors know how potent a medication is that we're giving. You'll develop 100 times as likely to develop an opioid use disorder than one that does not have prescription opioids prescribed. But we also know that this happens much earlier as well. So the risk of developing an opioid use disorder, if you're prescribed an opioid longer than 5 days, increases with time. And this is what these studies are getting to. The longer that you're on an opioid, the more risk you have. Now, there are some people that really need opioids for chronic pain conditions, but those are monitored under a physician. And even in those instances, as we know from the opioid epidemic, it's still a risk. So yes, prescriptions are given by physicians, but there's always an inherent risk with the opioids of the potential of developing an opioid disorder. But the real problem comes in with when patients start using opioids in ways that they shouldn't under the guidance of a physician. Now, one of the other things that I hear about often is, well, wait a minute, addiction was a choice. Why do we care? I mean, this was their fault. They did this to themselves because they chose to try a substance. Well, that's patently it's a false assumption, right? I mean, that's not really the right way of looking at this. And the reason is we don't have that same thought process when it comes to chronic conditions. So for example, diabetes. We know there's a genetic component to diabetes. We also know that lifestyle plays a role in someone developing diabetes as well. So for example, if you don't have a good diet, if you have a job that's stationary, that you don't have a lot of movement, if you don't exercise, all of those can contribute to a person developing diabetes. But we're not going to look at that person and say, well, you made all these lifestyle choices, so we're not going to really treat you because you don't have a disease. You brought this on yourself. No, I mean, that's patently false. We know that the pancreas is affected and we know we can treat you despite, this being 100% genetics or not being genetic or lifestyle playing a role in it. And we need to have that same understanding when it comes to addiction as well. And this is a slide that really gets to the point of these involuntary compulsive cravings that they can't control. It really isn't their choice. What you'll see here is that you'll have a brain that's in the scanner, and you'll see that they're being shown a nature video. And what you'll see is that little red area on the prior slide, that's not lighting up. That's the memory of the euphoria that they felt with that substance. But as soon as you show them a video of someone talking about cocaine, you'll see this area light up here, that memory center, which is going to drive that purple area. And again, they're going to go and they're going to use because the brain is screaming for them to use. So what's the best way to describe cravings and involuntary compulsive use? And I found this article in USA Today where a patient really truly described what it is they go through when they have this. So imagine that you have a patient and she's shaking her head and trying to hold back tears, and she says, it's like God tells you that if you take another breath, your child will die. She goes on to say, you do everything you can not to take a breath, but eventually you do. It's like that. It's like your brain just screams at you. And that really is truly the best way to describe what these cravings and compulsive use feels like. And you can try this yourself. Even if you have the best intentions to not take another breath, your brain is going to override that and you're going to take a breath. And that's exactly what these patients are going through. Another stigmatizing thought that I have to contend with a lot of people is this thought that if you relapse, you're not really committed to your sobriety and you're not really serious about turning things around. Well, I mean, that's really false. So if we look at the relapse rate for traditional medical diseases, as defined as you're not listening to your physician, you're not really doing the dietary or behavioral modifications that we're asking you for, you have an exacerbation in your illness, which requires you to go back and retitrate your medication or needs a hospital stay to stabilize and then get discharged. If you look at the general picture of what we consider a relapse, and you'll see that when you compare addiction to diabetes, hypertension, and asthma, it's no different. Yet for these conditions, we're able to work with patients. We don't discharge them from the clinic. We adjust medications. We circle the wagons around and we give them more care. But we're not willing to do that when it comes to someone that relapses on drugs. We're quick to say that, you know, you have to go somewhere else. We're not going to treat you anymore, or we're not going to provide you more resources. And that's the complete opposite of what we really need to do. The other thing that we have to realize that it takes time for your brain to heal from an addiction. So this is a healthy control. And what you can see here in the red are dopamine receptors in the brain. And this is an individual who has used methamphetamines. And they're 1 month abstinent from using methamphetamines. And you can see that even though they've been sober for 1 month, they haven't quite recovered to the level of a healthy brain. And if we look at 14 months after they've attained abstinence, then you can start seeing those red hues come back, but they're not quite at the level where they were with a healthy individual. So what I'm trying to say is it takes time for your brain to heal from an addiction. And with that time, it takes patience and understanding from physicians and from society in general to understand that these patients need time to get better. And there's a paper that shows that on average, it takes about 9 relapses once they enter treatment in order to fully engage in and attain 1 year sobriety under the care of a physician. So it takes time, you know, and just like any other disease, it takes time to heal. Selective forgiveness and understanding. And the reason I put this slide is to really drive the point that we're willing to understand individuals that suffer from various chronic medical conditions, but we don't view addiction in the same light. And we know it should be viewed in that light. So this is an example of an individual that comes into a physician who's overweight and says, I tried exercising or joining Weight Watchers. The physician says, try exercising or joining Weight Watchers. But if you don't, I'll understand. And that's the same level of understanding that we have to have for our patients that suffer from addiction in order to get them into the care that they need. So let's go over medications that are FDA approved for treating opioid use disorder. And all 3 of these medications are very good at treating opioid use disorder. There's some subtleties. The first one is methadone, and that's traditionally given at a opioid treatment program, not in an outpatient setting such as where I practice at family health centers. But it's a very effective medication, and if patients are stable on this medication, they should continue on that medication. Now, I'm going to focus more on buprenorphine and naloxone, or naltrexone, actually. And the reason I'm going to focus on those is because these are medications that you can receive in the outpatient setting, such as with your primary care physician, a psychiatrist who specializes in addiction, such as myself, at a place like family health centers. And you can also receive these medications in the emergency department if you need to. The first one is buprenorphine. And that comes in tablets, sublingual strips, which are the more common way that we prescribe in an outpatient setting. There's also this long-acting injectable formulation, which is Sublocade, that's given on a monthly basis. And then there's naltrexone, which comes in an oral tablet, but also in a long-acting injectable called Vivitrol. So these medications that I'll go into much more detail in the following slides, they are very, very good at treating opioid use disorder. They are incredible medications. And if once patients get on these medications, they do very well. This medication helps reduce cravings, withdrawal symptoms. It reduces overdose deaths. It reduces disease, such as the transmission of hepatitis, HIV, violent crimes. It also improves treatment outcomes, not just for the opioid use disorder, but across the board, meaning that patients that stabilize on these medications and get a hold of their opioid use disorder will do much better in their general health as well, when it comes to all the other ailments that they need treated. So one of the unfortunate things is that these medications carry stigma with them. And it's a lack of understanding of what these medications can do for patients and what they actually do. So let's go over some slides regarding what these medications do with the benefits that they have so that we can reduce this stigma and not have these patients feel singled out and as if they can't continue this medication, which they need to on a chronic basis. The first stigmatizing thought that many people have with these medications for opioid use disorder is that it's substituting one drug for another. And that's not what happens with these medications. That's a very poor understanding of what these medications truly do. So if you look at this chart here, what you'll see is on this axis right here, which we call the y-axis, you'll see three different states. You'll see a withdrawal state, a normal state, and a euphoric state. Which this means is that this normal state is our normal physiology. This is like anyone, any individual that does not have an addiction or an opioid use disorder in this example. And what you'll find here is a euphoric state, which is a high associated with the drug that they're using, and then the withdrawal that one feels when they stop using the drug. Now, you'll find that we have an acute use, which means a short period of time, chronic use, which is a long period of time. And what you'll find is those individuals that use opioids for a short period of time, what typically happens, and this is what happens with most individuals that experience an opioid, is that they'll find some kind of pleasurable effect, some euphoric effect from this substance. And that will trigger ongoing use for those that have a predisposition to developing an addiction. And eventually over time and over frequent use is that you'll notice that the euphoria starts coming down and they start transitioning into this withdrawal state. This withdrawal state is because your body became tolerant to the substance. And now what I commonly hear when I have patients come into care is that they'll say, "Doc, you know what? I'm not using this stuff to get high anymore. I'm just using it to feel normal now." And this is what they're referring to. What they're referring to is that they need to take this substance, this opioid, in order to just feel physiologically normal like you and I. So what these medications do that we use to treat opioid use disorder is that they bring them back to this physiologic level. They don't produce a high, an elevation. They don't produce withdrawal symptoms. They bring them back to normal functioning physiology, okay? The other question I often get is, well, how long should you be on this? Well, the real answer is that we know from data that you need to treat this like a chronic condition, like you would diabetes or heart disease or any other chronic condition that you're dealing with. Hypertension, for example, is another one. And you need to take these medications for the rest of your life. That's what we know from the data. We also know that if you stop these medications at 3 months, 5 months, 8 months, or 12 months, we have the same result. Patients do not do well. They fall out of treatment, they relapse, and they have a higher risk of dying. But so long as you keep them on the medication, they do well. We also know that these medications are great at decreasing mortality, and this slide outlines that. So if we look at the general population that doesn't have an addiction and their general mortality rate, and we look at those with a opioid use disorder, for those that are not in treatment, you can see that the mortality rate is significantly higher than the general population. But just by giving the medications that I outlined previously, you bring down their mortality rate closer to that of the general population. It's amazing what these medications can do. So let's look specifically at buprenorphine, also known as Suboxone. which is here in this film formulation and which you take under the tongue for treating opioid use disorder. And this is a study that looked specifically at that medication and what the effects were when it was given in Baltimore. And what you can see here is you can see in red heroin overdoses over the time span of 1995 all the way to 2009. You can see here on the line that's dashed with breaks in the middle, that is patients on methadone. And you'll find buprenorphine here on the bottom line that's dashed. Well, what you can see here is that as heroin overdoses increase, the city of Baltimore started prescribing more and more methadone, and eventually they were able to turn the tide, right? But despite giving more and more methadone, we had an increase in overdose deaths here that was trending upward. And the question is often why? Well, the reason that happened is because it's difficult to access methadone for many patients, and there's a whole lot of that goes into that. But just for the purposes of this talk, it's not as easy to access methadone as it is to go and see your doctor in the primary care setting and have buprenorphine prescribed. And that's essentially what we saw here. Once we started prescribing buprenorphine or Suboxone, that really turned the tide in the city of Baltimore. And this medication, for that reason, is what we really go to as a gold standard in the outpatient setting. Now, when we look at naltrexone, otherwise known as Vivitrol, we'll find the same kind of characteristics here, which is if you compare the active component, meaning Vivitrol, to placebo, you'll see a clear separation here with the number of free opioid days that a patient had, meaning sobriety. You'll also see that cravings are much better controlled for that population that has received the medication than those that have not. So it's a very effective medication. It's different than buprenorphine, and there's a reason why we give buprenorphine more than we give naltrexone, which I can discuss later if there's a question about that. But these two medications are very good at managing this condition. One of the sad things, unfortunately, is even though we have these medications available and we know how to treat this condition of opioid use disorder, and we know it's a chronic medical condition, and we know that we can have good outcomes, that access to care is still not where it needs to be for this population. We know that for people that suffer from an addiction in general, only 1 in 10 will receive treatment. That means 90% of individuals that suffer from an addiction will not have access or will not reach out to receiving treatment. And that's an unfortunate thing, because we could truly turn the tide around if we just increase our availability to provide this medication to those suffering from addiction, and patients are able to come in because there is no stigma, and stigma plays a big role in this as well. These patients have dealt with stigma all their life, so they're not inclined to want to go and seek treatment either, because we've shunned them for so long. So there needs to be a change with how we manage this. Lastly, naloxone. Narcan reverses opioid overdoses. It's available in the state of California to patients without a prescription, family members without a prescription as well. Physicians can prescribe this. I encourage all of you to please, if you know someone that suffers from an opioid use disorder, or if you're prescribed opioids, or you're prescribed benzodiazepines in combination with opioids, have this available to you, because this truly is the one thing that changes lives, meaning it saves lives in the community. And it may be that time that you save that individual's life that gets that patient into treatment and really has the impactful change that needed to take place. There's 4 formulations of this. This is probably the easiest formulation to use, which is a nasal spray. You just put it up to the patient's nose and you hit the plunger and it sprays naloxone or Narcan. This is another example of Narcan. It's a very expensive formulation, but I put it up there for purposes of presentation. And for those that don't have insurance, this is the cheapest way to get Narcan to them, which is a syringe. But for the vast majority of people, I really recommend this nasal spray. It's easy to use and accessible to everyone. And here are my references for the talk, and I think we will end there. Charlie.
All right. Thank you so much, Dr. Sepulveda. We have a time for a few questions. If anybody would like, you're more than welcome to submit questions into the chat. Right before we started, I think we had a few questions come in from our friends over at NAMI. So Dr. Sepulveda, I'm just going to give you some questions right now. The first one is, sorry, one second. Bear with me here. All right, Dr. Sepulveda, does MAT maintain efficacy at any stage of OUD? For example, is MAT more effective for someone who has had OUD for 5 years versus someone who has had OUD for 3 months? And really what we're asking here is it better to try other treatments before introducing MAT?
Yeah, okay, so that's a good question. I think there's some subtleties to that question as well. So the first question is, should we try other treatments before we try MAT? So we know from years and years of studies that if you employ psychosocial treatments into patients that have opioid use disorder specifically, and we'll talk specifically about opioid use disorder right now, that you're not going to have the outcomes that you will have when you employ medication-assisted treatment. Now, we also know from a study that for those that are prescribed medication-assisted treatment with the medications that we give, if you take that population and you take a population that was given psychosocial interventions with medication-assisted treatment, the patients that had the medication do just as well, if not a little better, than those that had the psychosocial interventions in that one study. Okay, so what does that say? It doesn't dismiss that you can't use these psychosocial interventions in order to improve your treatment outcomes. And we do that at family health centers. But what it really says is that you need to prescribe these medications to these individuals because these medications alone will have all the outcomes that you want. You want to decrease mortality. You want to decrease withdrawals. You want to decrease cravings. You want to decrease relapses. You want to decrease their ability to get infections. You want to decrease all the medical issues that are going to happen from ongoing use. You want them to go back into society and work and do and become productive members of society. You want better outcomes for the families of these individuals. All of that happens with just prescribing the medication. Okay, it truly does, study after study. So what I'm saying is, this is really the gold standard. You really need to make these medications available to the patients and employ all the other psychosocial interventions, but you don't need the psychosocial interventions to get all the benefits that you would get with the medications.
Thank you. They have a few other questions too. What are the most effective ways to address MAT stigma to individuals with OUD who are hesitant about it?
Yeah, so that's a very important question, and stigma exists not only in a variety of settings. So, for example, it exists amongst prescribers, meaning physicians. It exists among family members. It exists even in these treatment centers where patients go and get treatment. Even amongst the patients, patients will often say, "Well, they have their own interpretation of." You're not sober because you're on this medication. So we see that with NA, with AA, and that's unfortunate because it really does a disservice to the patient and all the benefits that they could get. So what really needs to take place is there has to be a change in viewing this condition as addiction, which is a behavioral problem. And we need to change it to thinking of addiction. This is a chronic brain disease and we can treat it like any other chronic illness that we treat. If we change our thinking cap to that way of approaching it as a medical condition, then everything changes. And we've seen that here at family health centers when we launched the MAP program, right? We approach this as a chronic medical condition for our providers, for families, for patients. We've worked with organizations out in the community in order to change their thought process. I've given talks to members in the community. And slowly and surely, the tide is changing to that pattern of thought, and our patients are getting much more benefit from it. So it has to be a cultural change from a societal level where we start viewing this for what it really is, which is a chronic brain disease.
Dr. Sepulveda, I have a question. Are you amongst the community of providers, are you starting to see a shift in thinking in what providers other than yourself and what their perspective is on patients like the ones that you've discussed today?
Yeah, I am. Had you asked me this about maybe 8 years ago, it would have been a different answer. But it's well known, it's well published. We know how big of a problem it is, and we know the treatment benefits that we get from employing medication-assisted treatment. I must also say that the younger crop of physicians are much more inclined to really treat this condition as well, and really are savvy as to what's going on. And that's just a function of all the data that we have now of how well this works. That wasn't available when I trained. When I trained, unfortunately, a lot of physicians, individuals in the community, politicians brought their own baggage along with why the reasons for how they were going to approach this illness and their own experiences with addiction as well. But we have much more data now. We have a much clearer understanding of what this really is, and we have a really good understanding now of how to get patients better.
Yeah. Have you seen, obviously, this topic, the lawsuits, everything has been so publicized in the media in the last 2, 3 years. Have you seen the publicization, if that's a word, of the opioid crisis in America? Has that helped the maybe hesitancy of these patients in coming forward and seeking treatment, or has it made it more difficult?
No, I think it's helped. I mean, when you have more publications out, that causes more awareness and understanding of how big of a problem it is, and individuals like myself start being heard more because they know, well, this individual treats this condition, we should listen to them, as opposed to not having any knowledge of what's going on. So no, it's helped a lot. It's really helped bring the conversation to stigma and how big of an issue that really is. The war on drugs was a war on drugs, and it hasn't changed anything. I don't think anyone out there, from a political standpoint, a law enforcement standpoint, from a treatment standpoint, could really say that the war on drugs really made any dent in, addiction or making it any better. There's a clear conversation now that's happening even with law enforcement. You can see that by just having, DA Summers here, that there's an acknowledgement that we can't just police ourselves out of, addiction in America. We really have to treat it for what it is, which is a medical condition, and give patients the same care that we give for any other condition. And I say that over and over again, but that really is the way that we're going to turn the tide around.
Thank you. So apologies in advance because I know I'm probably not going to pronounce this correctly. This is from Alexander Ball of NAMI. Dr. Sepulveda, how does MAT affect hedonic allostasis?
I'm not really sure I'm following the question.
Okay. Yeah, well, since I'm not a provider, I'm going to move past that because I have no idea what that means. We have a question from the audience. Does the level of stigma vary between the different types of addiction? So, for example, alcohol is readily available, and since this is the case, would individuals struggling with alcohol addiction face less stigma than individuals with an opioid addiction?
Yeah. I think there's grades of stigma based on the addiction that a patient has. So let's take this back to an example of the 80s, right? We saw cocaine and crack cocaine was a big problem in the inner city, and we saw that those that were affected were disproportionately minorities, and they were being incarcerated at large rates. But cocaine, which is the same thing as crack cocaine, the only difference is the formulation, right? One is a powder, one isn't, one is smoked. Cocaine was prevalent in Wall Street and in white collar society, and it was used. But yet, if you were caught with cocaine, it was a slap in the wrist. You didn't receive the same level of incarceration that those in the inner city were receiving. And that was because of stigma, right? That was completely because of stigma. There's no rhyme or reason why you should have approached the two in any different way whatsoever, right? It's the same substance. And the way it should have really been treated is the way we're treating addiction now, is with compassion, with understanding, with treatment that's available. When it comes to alcohol, opioid use disorder, methamphetamines, yes, there's even among, communities of recovery, so to speak, there's stigma associated with you using one versus the other. And is it okay for you to be on a medication for opioid use disorder? Well, no, it's not okay. But if you're using alcohol and I give you a medication for alcohol or to help with the alcohol issue, that's okay as well. And there's a wide variety of, thought patterns, none of which make sense, right? It's all people's lack of understanding of what addiction truly is. But whether it be heroin, whether it be cocaine, whether it be alcohol, whether it be cannabis, Addiction is addiction, and it works the same way in your brain, and they need treatment.
So I'm not, it's been about a year since we did a separate webinar on mental health as a result of the pandemic. And looking back, we saw a great need for mental health resources and services as we looked back and saw maybe some of the invisible impacts of the pandemic that it's had on our communities since. During that webinar, we didn't really talk about the opioid crisis. So now that we're further out, we're a year out, Dr. Sepulveda, I'm wondering, what have you seen as some of the effects or changes or nuances that the pandemic has had on the patient population that you've been treating?
Yeah, no, that's a good question. I mean, without a doubt, we've seen an increase in addiction with the pandemic or substance use. We've seen an increase in overdose deaths. And there's a lot of reasoning why that happened. Well, or a lot of thoughts I have as to why that happened. First is the pandemic caused the unfortunate closing of many treatment centers because of, we didn't know what we were dealing with, and some centers said, well, this is non-essential treatment, so we need to stop it. And that was the first problem, right? That had a bit of stigma too. They were viewing addiction treatment services as non-essential, which really it is essential. It's just as essential as any other medical condition that we treat. So that was one. The other thing that we saw was that the drug supply changed. So people were, just like we're having a hard time getting goods. I'm currently in the process of remodeling a home, and I can't get the goods to remodel my home because of COVID and the supply chain disruptions. Same thing happened with substances. There was a disruption in the supply chains, and what ended up happening was that fentanyl started taking more and more of the place of many of the substances that you're having a hard time getting, largely because of what I said earlier, which is it's synthetic. You can make it in the lab, you can mass produce it, and you can quickly, substitute for things that you have to grow. For example, like opioids, like heroin, you have to grow poppy seeds. So that's another thing that we saw. And the third strike really was all the mental health issues that happened with COVID. People that were already struggling with addiction and mental health issues had an exacerbation because of the COVID. We all know that, isolation and loneliness doesn't help with addiction or mental health conditions. Individuals that weren't suffering from mental health conditions or addiction issues were now going to using substances to self-medicate themselves because of the isolation that they felt and the depression that they felt. And we also know that people that weren't dealing with mental health conditions had an exacerbation of developing mental health conditions such as depression and anxiety because of the pandemic and isolation as well. So there was a lot that was going on there, and there was stress at home. You had to not only care for your kids and go to your work, but also teach your kids at school with homeschooling. You never had experience with that. So all of that stuff contributed a lot to not just not just using the substances and alcohol. We knew alcohol sales went up significantly as well, but developing those mental health conditions as well. And people weren't treating their issues when it came to physical health as well. So pain conditions weren't being treated. And, that also exacerbated things as well. So it's unfortunate what happened.
Yeah, that makes sense. As we look ahead, what do you think is kind of like the plan of attack and treating and hopefully working to cure the opioid crisis in America? What does that path look like for us?
Yeah. So I think one of the first things that we have to do is increase access to medication-assisted treatment. By far, we need to increase it. So the unfortunate thing is that even though we have providers out there that can prescribe buprenorphine, the vast majority don't utilize their X waivers. And X waivers means permission from the federal government to prescribe buprenorphine. They don't utilize it up to their cap, meaning they don't take full advantage of the number of patients that they can treat. The other thing that we need to do, and I think this is a bigger issue, is there needs to be much more funding for addiction in general. And that's not just with opioids, that's with everything. I think the third thing that we need to do is that everyone from, and I said this before, but it's worth saying again, everyone that is exposed to this illness needs to change the way they think about this illness. That's not just from hospitals or treatment centers, but it goes to our politicians, which are already showing a change. They've already really changed the way they've approached this from years back. To local organizations, to local law enforcement, to family members, to those in school who are educating our youth. We need to really view this for what it is, and that is a medical condition. And we also need to look at the data and really employ and use what we know works. So for example, in this condition, it's medications. We need to use medications. The days of being in a sobering center and withdrawing and hoping that you can white knuckle yourself out of this and you're going to do just fine, those days are over. They don't work. We have something that really works, and people just really have to adopt that and really understand that.
Yeah, thank you. I saw that we have one more question from a gentleman named Diego. Diego, for the sake of time, I'm going to follow up with you via email. But with that, I just want to thank everyone so much for attending our webinar, and thank you for joining us today. As always, I want to remind everyone that our webinar is going to be shared early next week, so keep an eye out for that, please. And once again, thank you to our fantastic family of Spirit of the Barrio sponsors for supporting our work here at Family Health Centers of San Diego as we serve the community in which we live and serve. Dr. Sepulveda, I want to thank you personally. I appreciate your leadership on this. Thank you for your time, for all the work that you've done. And to everyone, stay safe, have a great weekend, and until next time, have a great Thanksgiving. Thank you everyone so much. We appreciate it. Thank you and goodbye.